So what I want to focus on is this concept. Dr. Nikas is going to talk really about the Chiari more. I'm going to focus on Syringomyelia and Syrinx and its relationship to Chiari. And just a disclosure, I'm a founder of one of the oncology apps, but that has nothing to do with this talk, but I need to disclose that. The clinical questions that I want to address today are three. What is the relationship between scoliosis, Syrinx, and Chiari? And should I have Chiari surgery if I have both scoliosis and Chiari without a Syrinx? Would that help my scoliosis? And would surgery for Chiari help my scoliosis if I have a Syrinx? And what do we do about the Syrinx? So these are questions that we see all the time. And I want to first touch base on a little bit about scoliosis. So what we see on the far left, I don't know if I have a pointer here, but on the far left, that is kyphosis, where the shoulders are bent forward. The middle picture is lordosis, which is arching of the back too much. And the right picture is scoliosis, which is a sideways curvature of the spine. And that's technically what scoliosis is. And it can come in different, the curve can be at different places. And these are some of the different locations of the different types of curves. And they're measured in degrees. And then there's a combination of curves where you have a mixture of the scoliosis with the kyphosis and lordosis, and it can become very complicated. Scoliosis occurs in general population. About 3% of the population will have scoliosis. And it's usually female and usually 10 to 20-year-olds. And it's so common that you don't get MRIs on the typical female adolescent patient with scoliosis. There are a variety of different types of scoliosis, and the ones that I want to point out, there's really four main types. Neuromuscular, meaning that the muscles around the spine are affected so that the spine doesn't have the support and it grows crooked. Idiopathic is the most common type, where they don't have, it's just a young female developing this without any other problem. Congenital, like if the bones are crooked, or one's missing, or one's hemiblack, or other things. And then a miscellaneous group. What I want to focus on is the neuromuscular with Syringomyelia involved. We'll talk about that, but we also have to be mindful that Chiari patients can have this Ehlers-Danlos syndrome, and that can itself be associated with scoliosis. And so it becomes fairly multifactorial sometimes. Scoliosis, this is the Adams forward bend test. So if your doctor asks you to bend forward, and this is the reason why, and the pediatricians will put what's called a scoliometer on your back, on the back, and measure that angle that we see in the middle picture. If it's over 7 degrees, it's awfully, at that point, the patient is sent for ortho spine referral. And this is typically what the x-ray looks like. When do you get MRI scans on people with scoliosis? Well, the typical scoliosis is, when you look at it, it's the right side is humped, for the convexity is on the right. It's unusual to be a male with it. It's unusual to have a left-sided scoliosis. And so it looks like those would be two indications for moving forward with MRI imaging. Another thing, and this is what's called the superficial abdominal reflex. This is what a lot of ortho people, spine doctors, do. And it's rare that I actually end up doing this, because the patients usually come, they're already diagnosed with this. But this is what's called an abdominal reflex. And basically, the doctor will take this thing, and you see that it's kind of scrunching when you touch it. That's normal. A normal reflex on the patient's left side here. But on the right side, the patient does not have an abdominal reflex. So something's going on. And I've had ortho spine doctors just pick up send a patient for an MRI based on that alone, that they saw abdominal reflex absent. Treatment of scoliosis, a lot of times, is observation. If the degree is very minor, it's a watch and wait type of thing, or brace. And then surgery. And surgery can be quite extensive. I work a lot with Dr. Steve Margecko, one of the national experts in scoliosis surgery, and This is one of his patients. You see before surgery and then after surgery. It's often extensive. These are operations that can go from stem to stern with lots of instrumentation and sometimes often stage procedures. It can be a very big deal. Some of you may have experienced this. Let's step back and talk about syringomyelia for a second. This is fairly common in the Chiari population. In the general population, it's about 8 per 100,000, usually in the middle age group. And the causes are generalized into idiopathic versus secondary. And I want to tell you, this is Greek Easter, and I know Dr. Nikas just walked in. He's challenged this weekend because of all his commitments. But from the Greek mythology, the word syrinx comes. I find this fascinating. So there was a wood nymph named Syrinx, and she was pursued by this Greek god Pan, who's a god of the forest, the god of fertility. Below the waist, he's horse. Above the waist, he's human. And he would chase after all these nymphs he had his eyes on Syrinx. And this is Pan. And Pan was always after Syrinx. And he got very close to sort of capturing her, let's say. And the nymphs of the reeds changed her into a reed, changed her into one of these reeds. And narrowly, she escaped Pan's amorous attacks. And here's another picture of Syrinx. And you can look down at her feet, seeing how she's being turned into a reed. And there's Pan. When she turned into a reed, Pan all of a sudden lost her, and Pan screams out in his scream. And that now is the reason the word panic comes. Panic is from Pan, from this thing. Syrinx means hollow tube. This is a syrinx, but she turned into a hollow tube. And then Pan takes the reeds, he cuts them all up, and he plays the reeds now, and it's called a pan flute. And he is forever playing, because that's where Syrinx is. And if you Google the god Pan, you'll come up with a lot of interesting images of Pan. What's the cause of Syrinx? Idiopathic, in other words, it's just there, versus secondary. And Chiari is a very common cause of Syrinx. And here you see a Syrinx right here, and the Chiari malformation in this particular type. But Syrinx can be also caused by other things. It can be caused by inflammation, trauma, tumors, and other reasons. There's some great talks on this website. This organization sponsors, and here's some of the ones. Dr. Studley, if you really want to get into the science of what causes syringomyelia, an excellent lecture by Dr. Studley, and Dr. Forster and Dr. Heiss have given lectures on this topic that are fantastic, and a great resource is the csfinfo.org, soon the Bobby Jones website. So how do you know what happens when you have a Syrinx? You get a loss of pain and temperature in a cape-like fashion. And that has to do with the fluid expanding, infecting the cross-section of the spinal cord where the pain and temperature fibers come out, and gives us cape-like formation. And then progressive scoliosis, and then withering of the hands. Wasting of the hands is often something that happens as this advances untreated. There's some great new work on looking at the dynamics using functional or dynamic MRI imaging, where you can actually see how the spinal fluid is flowing. And you might have had that done at the cranial-cervical junction for Chiari, but they're doing it now in the lower part of the spine, where somebody has an isolated Syrinx without Chiari, and finding in a lot of idiopathic Syrinxes that there's actually an arachnoid band that disrupts the spinal fluid flow and causes a disruption, so the spinal fluid goes into the spinal cord. It's very interesting, and I think a lot of idiopathic Syrinxes are going to be reclassified. So what about Chiari's relationship to this? And this is, I borrowed this from an article that has had such a nice display. Here's a Chiari 1 with the Syrinx. You can see the little white streak in the middle of the spinal cord, and the typical, not typical, but left-sided scoliosis, which is a little bit unique in a 9-year-old boy. So this is what we sometimes see with, this is a great article by Cormac Maher and Karen Marasco from University of Michigan, and they looked at this relationship between the different factors. And they took all kids that came in there that had an MRI done for cervical MRI or brain MRI, and they just looked at them and see what's the incidence of how often, when you just look at everybody's MRIs, would you find a Chiari, would you find a Syrinx Scoliosis? And this is what they found. Now I said that, you know, scoliosis is only about 3% in the population, and they have 12.8%. So obviously the people who are going to the University of Michigan getting tests are not just, oftentimes have scoliosis or some problem to get the test. And this series sort of reflects that. But it's such a large series, it gives a lot of information about what to look for with people who have these conditions. So scoliosis, in those x-rays of images that showed had scoliosis, 8% had a Syrinx, 6.6% had a Chiari, and 4% had both. And it's really interesting because what they did is they looked at the factors and said, okay, look, what are the associated factors? If you just had a Syrinx, what would be associated? And what they found was that Chiari was associated with scoliosis only when there was a Syrinx present. But when there wasn't a Syrinx present, there was no association of Chiari with scoliosis. That's very important, because there's a lot of neurosurgeons out there who are operating for scoliosis correction just because you have a Chiari. And I'm going to talk more about that. It's probably something that we should reconsider based on the recent data. If you have a Syrinx and scoliosis, then it makes good sense in many cases, but we'll get into that. This is an excellent recent, published just a month or two ago. This Eric Davis is a medical student, did his thesis as an ortho at Harvard. Dr. Michael Glotzbecker, the peds orthopedic, proctored him. It's a wonderful, wonderful article about Chiari malformations and the importance of Syrinx. So here's Syrinx again in pan, and we're going to look at what happens when you do surgery for Chiari, when you've got all three things. You got the Syrinx, you got the scoliosis, and you got the Chiari. Well, scoliosis improves in 40% of the patients. It stays the same in 27%. And it continues on as like nothing happened in about 1/3 of the patients, even though you've operated. If you're less than 10 years old, then the scoliosis did better after decompression than if you're older. So we'll remember those numbers. About 2/3 of people would benefit from surgery for Chiari if you have scoliosis and Syrinx. It either stabilizes it or it 40% of the time get better. And getting better means a 5-degree improvement in curvature of the Cobb angle. Again, here's Syrinx and pan. And so now Syrinx, if you have a Syrinx and if you have Chiari and scoliosis, decompression improves the scoliosis. If the Syrinx shrinks. Now, I've had patients who have operated for this, and afterwards the Syrinx is the same. And so that doesn't count. You have to then get some reduction in the Syrinx if your goal is to get a reduction in the scoliosis, if that's your goal. And you're less likely to need major orthopedic surgery in this situation. If your curve is really bad, then this is still a big problem, and more likely to still need the scoliosis surgery. So what about if you have scoliosis but no Syrinx and you've got a Chiari? You've got a Chiari, you got the curve in your back, but you don't have a Syrinx. Decompression does not improve the scoliosis. That's the new word out on this. And there's a lot, this group actually has a very favorable outcome with bracing, which is interesting. So why does a Syrinx lead to scoliosis? this is a thought, the expanding syrinx causes damage to the anterior horn cells of the spinal cord. Those are some of the motor fibers that affect the paraspinal musculature. And you get an asymmetric weakness to some of the muscles. Some of the muscles are strong, some of them are weak, and you start to get the curvature in the coronal, meaning sideways crookedness of your spine. Decompression surgery improves. There are studies done where they looked at, after you decompress somebody for Chiari, does the musculature get stronger again? Do the nerves start to work again? And yes. So that's another indication of why Chiari causes the scoliosis. So a summary. The Chiari alters the basic spinal fluid. This is how Chiari is related to Syrinx is related to scoliosis. Chiari alters the basic CSF pathways at the top at the foramen magnum. And this causes the development of the Syrinx in many cases, not all. The Syrinx then leads to impaired innervation of the musculature and then the development of scoliosis. That's sort of it in a nutshell. Now, let me tell you the thing that makes this interesting, the caveats. Okay, that seems simple, right? You've got a Chiari, you've got Syrinx, you've got scoliosis. Oh, automatically you need surgery. Well, hold on, because 9% of patients who have that situation get better without surgery at all. So 4 in 10 patients get better with surgery. 1 in 10 patients gets better without doing anything. And you got to be careful. And this is why I distinguish adult. I take care of adults and I take care of children. Children are changing. They're growing and developing. And a growing child, there's many reports of improvement in the Chiari and or the Syrinx without any surgery at all. And I'm sure Dr. Nikas has it. All of us neurosurgeons have this. And I'll show you a couple cases of mine, patients of mine, who come in minimally symptomatic with Chiari. And here's one at age 5, one of my patients. And you can see the Chiari at the very top, how tight that looks. You don't see a lot of white spinal fluid around the foramen magnum. And you see the big white tube in the middle of so here's C1. Here's the Chiari coming down to C1. Here's the Syrinx at age 5. No surgery's done. And then at 5 years later, if they're relatively asymptomatic, mild headaches, mild this and that, and they're growing, I tend to be conservative. And this is why. Now look at this. The Chiari is moving up. It's more room. You got more spinal fluid around here, and the Syrinx is starting to shrink. And the child is fine. I'm waiting. Another 5 years, I'll get another MRI. And we'll see. A lot of people can avoid surgery because they basically outgrow this. And that's an issue. Who outgrows it and who doesn't? Here's another one of my patients. This is a 5-year-old child that came in and had Chiari symptoms. Here, you can see the cerebellum extending down to C1. It's relatively tight through here. Minimal symptoms, but still symptomatic. Mild headaches intermittently and other issues, but not no neurologic issues. And this time, 6 years later, MRI was done. And now look at the back of his brain. Here we are. Totally normal. No one would say he has a Chiari. Do you have a Chiari for your life when you're born with it? No, you don't. Here's an example of one. Okay. If you look back here, the cerebellum's up in the normal position, nice and rounded. Here's the arch of C1. So these are the things that we have to pay attention for. Okay, and as we're learning more about Chiari, is in the growing individual, they're a different patient than the patient who is an adult and has already reached their maturation, and then you can't expect change or improvement with aging, except in the very elderly patients, where the brain is actually shrinking from normal aging process. That may help in some of the Chiari symptoms. What else? So be careful, okay? You got Chiari and you got scoliosis. Consider other causes. And like I mentioned, Ehlers-Danlos syndrome is another cause of scoliosis, independent. So you know, if you operate on a Chiari for scoliosis without a Syrinx and the patient has EDS, things could fall apart, requiring surgical fusion, other things. And the neurosurgeon who says, well, you've got a crooked spine, you got Chiari, you need surgery, and you don't have a Syrinx, this is something that we're learning that we better stand back on. So to get back to the questions that we started the lecture on, what is the relationship between scoliosis, Syrinx, and Chiari? So Chiari can cause a Syrinx due to CSF flow in some patients. And how many patients? Well, depends on what you're looking at. The people who usually come to doctors, it's anywhere from like 40 to 80% in certain series of people who come in with symptoms that have Chiari have a Syrinx. And that Syrinx can cause the scoliosis, but Chiari doesn't independently cause scoliosis. Should I have Chiari surgery if I have both scoliosis and Chiari without a Syrinx? The only reason to do Chiari surgery in that situation would be because of your Chiari. If you have Chiari symptoms, right, and you're symptomatic from Chiari for other reasons, but not because of the scoliosis. And what about if you have Chiari, scoliosis, and a Syrinx? Then yes, I think that surgery gives a 2/3 chance of stabilizing scoliosis and a 40% chance of improving your scoliosis, with the caveat that there are some patients that you could watch who might outgrow this and not need the surgery at all. So with that, I'd like to thank you and thank you for coming. And I'm sorry I have to run out on you, but really appreciate everyone coming here.